Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is chronic obstructive pulmonary disease, or COPD. So what is COPD? This is a chronic, slowly progressive airway obstruction which is irreversible, which is in contrast to asthma, which is reversible. COPD accounts for 7% of all UK deaths, and there is an annual prevalence of 6 to 7%. 80% of cases are due to smoking, but there are a small proportion that may be due to the rare condition alpha-1 antitrypsin deficiency. COPD is characterised by a multitude of signs and symptoms. From a respiratory point of view, of course, there is exertional dyspnea with recurrent chest infections. A polycythemia may be seen on full blood count. There may be evidence of cor pulmonale. These patients do tend to have a prolonged expiratory wheeze, and there is evidence of hyperinflation, particularly on chest x-ray. Hoover's sign may be seen, which is paradoxical inward movement of the intercostal muscles on inspiration. There may be expiration through pursed lips, cyanosis, and weight loss over time. As well as a history and examination, blood tests should be performed, which may show a secondary polycythemia. Arterial blood gas should be done for assessment of long-term oxygen use. A chest x-ray may show hyperinflation. Spirometry will show an FEV1 over FVC ratio of less than 70%. BMI should be monitored. From a cardiac perspective, an ECG and echocardiogram should be performed to check for cor pulmonale. A high-resolution CT scan should be performed if symptoms are disproportionate to the spirometry findings, or if unexpected findings are seen on chest x-ray. This is an algorithm taken from the NICE guidelines for the management of COPD on stepwise management of the condition. Management also involves multidisciplinary approach as per many conditions, and it's important to say this, particularly, for example, in PACES when you are presenting the patient. Smoking cessation is key, as well as provision of pneumococcal and influenza vaccines. Pulmonary rehabilitation will be required in the long term, as well as a personalised self-management plan. And it's also important to treat comorbidities which may interact with COPD in order to improve the patient's general health. Long-term oxygen therapy is indicated if the PO2 is less than 7.3 on 2 separate occasions, at least 3 weeks apart, or if they have a PO2 of 7.3 to 8 with pulmonary hypertension, polycythemia, nocturnal hypoxemia, or peripheral edema. There are also some surgical management options available to people with advanced COPD, and these include bulectomy, which would be performed in patients with breathlessness with previous CT-proven single large bulla, plus an FEV1 of less than 50% of predicted. Lung volume reduction surgery may be carried out for patients with reduction in activities of daily living, despite maximal medical therapy, including pulmonary rehabilitation. This would be done if FEV1 is more than 20% of predicted, and the DLCO is more than 20% of predicted, and PaCO2 is less than 7.3 kilopascals. It's also important to have upper lobe predominant emphysema as well. Finally, lung transplantation is reserved for people with FEV1 of less than 25% of predicted, with a PCO2 of more than 7.3 kilopascals or cor pulmonale. So now time for a question. A 65-year-old gentleman with known diagnosis of COPD is getting assessed for possibility of long-term oxygen therapy after recovering from a recent episode of exacerbation. Which of the following is not an indication for long-term oxygen therapy, or LTOT? So these are our options. We've got a PaO2 of 7.4 kilopascals with bilateral pedal edema, B, PaO2 of 7.9 kilopascals with signs of RV strain on ECG, C, PaO2 of 7.1 on this encounter, D, PaO2 of 7.8 kilopascals with raised hemoglobin count on FBC, and E, PaO2 of 7.6 kilopascals with cor pulmonale. So the correct answer here is C, because we only have one reading from which to make a decision. And you'll remember that we need to have 2 readings on the ABG at least 3 weeks apart before considering someone for LTOT. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.